It's a great privilege to be able to chat to you about some of the payoffs and pitfalls of evidence-based global health policy making. And I wanted to just kick off by getting a feel for how many people here are working in global health. You've got 4 choices. Yes, number 1, if you're a global health practitioner. Yes, number 2, you're a policymaker. Number 3, no, not at all. Or number 4, what's global health? It's not a huge amount of people working in global health in the audience. I hope that some of the lessons today are generalizable. In a way, I think that just as the local can be global, the global can be local. So I have a background in clinical medicine, but I now do consider myself a global health practitioner, something like an evidence broker, perhaps, in global health. I have a journalism background. I worked as a journal editor at the BMJ and PLOS, but very much focused on global health. And now I lead a small, new Gates Foundation-funded initiative called E2PI, the Evidence to Policy Initiative, at the University of California in San Francisco. And our mission is to try in some small way to narrow the gap between, on the one hand, evidence and evidence syntheses, and on the other hand, practical policy making in global health. So today, I hope that you'll come away with some knowledge of how decisions get made in global health, some of the barriers that get in the way of evidence being used, and then a few of the innovative solutions out there. And I wanted to set the scene with what I would call the tragedy of evidence in global health. And the tragedy is this. The good news is that evidence can matter, but the bad news is that it often does not. And that's a quote from a fantastic Overseas Development Institute paper on this topic. And here's a case study of the tragedy from a disease I do a lot of work on, malaria, which kills about 3,000 children a day. And malaria has become largely resistant to the old monotherapy drugs like chloroquine and SP. The great news is there's high-quality evidence from RCTs and systematic reviews to support the use of ACTs, artemisinin-based combination therapies, highly effective, made from the Chinese sweet wormwood plant, Artemisia annua, Qinghao Su. But the delay, the long delay in the national and global adoption of ACTs led to thousands of lives being lost unnecessarily. And the New York Times did a fantastic feature about this delay some years ago, and they interviewed the United States Agency for International Development, the largest malaria donor. And Dennis Carroll at the time said, well, you know, these drugs, they're too expensive, poor people won't take them properly, and they're not ready for prime time. An interview that I have to say upset an enormous number of people working in global malaria policy. And it upset this guy, one of the heroes of malaria in sub-Saharan Africa, Fred Binker, epidemiologist. And he said, look, in poor countries like ours, children get just one chance. They struggle just to get to a health center, and if they get the wrong drug, like chloroquine, they're then found dead. This was very much a life and death issue. But as I said, the flip side of the tragedy is that evidence can matter in global health. And here, I think, is a nice example of insecticide-treated bed nets. Now, if there's ever been a magic bullet in global public health, I would say that this one is pretty close. Reduces malaria episodes in half, reduces child mortality by 20%. And 2 papers published over the last year from Stephen Lim and his team in Seattle, published in PLOS Medicine, have been enormously exciting to the global malaria policy community. The first showed that international aid has been associated with bednet scale-up, a positive association. Roughly speaking, for every $1 of aid that a sub-Saharan African country receives, it's able to increase net coverage by about 5%. And the second paper showed that bednet usage in the real world, in 22 countries, observational data, but nonetheless effectiveness data, having a bednet in your house was associated with a 23% reduction in child mortality. Profoundly, profoundly important studies. So because I am an incredibly sad human being, this is what I dream about at night. I dream about a shift away from global health policies that are based on opinion or whim over time towards policies based on evidence. So the first thing I want to look at then is how decisions get made in global health. And I want to try and summarize about 30 years of social sciences research in 3 slides. This is, in some ways, the sort of holy grail for global health policymakers in thinking about how policies and decisions get made. It's Jill Walton, Lucy Gilson's health policy triangle, where whenever you look at a global health issue, you look at it through this lens of who are the people. Typically in global health, it's donors, it's ministers of health, malaria control program managers, and so on. What is the context in which decisions are being made? The political context, the economic context. Economic context right now, crucial, obviously. Global economic downturn has led, for the first time in 10 years, to a fall in aid for malaria. People are freaking out about that for understandable reasons. What is the content of the policies? And what are the processes by which decisions get made, typically board meetings or a new government? And how do these factors come together to shape global health policies? Well, there are several patterns that have been observed through social sciences research, and here are some of the common ones. Sometimes these factors come together in a linear way. I'd say that's rare, but BedNet scale-up has been reasonably linear. More often, it's incremental. Policymakers tend to be a bit nervous. They tend to want to test the waters, check with their constituents, make sure they're not going to upset anyone. And so often the changes are small. And I think a reasonable example of that has been in countries that had antenatal syphilis screening in place, adding HIV screening as an incremental step was reasonable. Or sometimes we see something that's been called the middle way, somewhere between a sort of a linear and incremental approach. I think we're seeing that a lot right now in child health, another area I do a lot of work in. In child health, there is an overwhelming number of evidence-based tools that could be scaled up to help us reach the Millennium Development Goal 4, the child health goal. We are way off course to reach that goal. There are so many tools, it's overwhelming. A middle way is to say, okay, let's pick a few that have a dramatic impact. So lots of people talking about how can we scale up ORT and zinc, how can we scale up antibiotics for pneumonia? Or it's all about power. We see that a lot. We see donors calling the shots a lot. I'm funded by the Gates Foundation, but a valid critique of the foundation is they have a lot of power to set agendas. And indeed, agendas and how they reach the top of the agenda, particularly maternal health, for example, reached the top of the agenda recently in global health for decades. Nobody really cared much, but interesting agenda setting and advocacy coalitions around that. So it's messy. It's a messy, complex, iterative interaction amongst what have been called the 4 I's: institutions, interests, incidents such as external events, the global economic downturn I just mentioned, and ideas, including evidence, the 4 I's of policymaking. So I wanted to pivot next to some of the barriers that get in the way of global health policymakers using evidence. And I wanted to get a feel for whether we have a cynical audience or a very optimistic audience. I wanted to get your opinion on whether you think global health policymakers use evidence or not. You've got 6 choices. They never use evidence, they just push their own agenda. They use it, but only to support their agenda. They sometimes use it, but it's pretty random as to how they do so. They sometimes use it, and there are some predictable patterns. They always use evidence in their policymaking, or it just depends on what they ate for their breakfast. Fairly cynical, I'd say. It's all about supporting agendas, and I think there's almost certainly some truth to that. I'm going to come back to a bit of research that's been done that I think can help to illuminate this question. So I wanted to examine some of the barriers that get in the way. Now, here is something incredibly idealized that we would love to see in the world of global health. We'd love to see tons of fantastic primary research relevant to low-income settings. We'd love to see synthesized evidence of that research. We'd love to see it reaching policymakers, policymakers using it, and then huge, large-scale change based upon that evidence. We've already seen that, first of all, this kind of linear policy making is rare, and that, I think, is a very real and a very obvious barrier. And some of the other barriers that I'm going to quickly touch upon are weaknesses in the primary research and the synthesized evidence, the fact that the evidence may not even reach policymakers. If it does, they may not use it, and there is this tremendously dark black box of implementation. Our knowledge, our science of large-scale change in global health is still pretty rudimentary. So there are barriers in terms of the primary research. There are still too few trials of global health interventions. But even going beyond trials, sometimes if I'm doing a policy brief for a policymaker, I would love there to be other kinds of evidence available. Value for money evidence, practical models of scaling up this tool, and often the cupboard really is bare. And increasingly, traditional research designs can be quite inadequate for global public health. Now, everybody at Evidence 2011 agrees that the RCT is the best tool for assessing a new biological or behavioral intervention. But very often, in global health policy, the question isn't, does this new tool work under controlled conditions? I'm afraid the question very often is more like this. How do we assess complicated, large-scale, real-world changes in governance, financing, architecture, delivery on a background of multiple overlapping existing programs? And it's a mouthful even to say it. And actually, yesterday, Trish and Paul, in their session on complex social interventions, touched upon this issue, this very difficult issue. And this might be my favorite slide. This shows just one low-income country. It's Mozambique. And it shows that in every single district of Mozambique, there are global health initiatives. There are millions of donors. There's the UK, there's the EU, the Americans, they're all there. And it's a messy mélange of donors and initiatives. And no district is untouched. Very challenging in terms of trying to assess a new intervention. A second barrier is that there are weaknesses in the synthesis itself. Systematic reviews are often not relevant to global public health priorities, and when we go out and try and review the evidence, often it's a very mixed economy. I mean, realistically, sometimes I go to do a policy brief, and all I can find are consultant reports from consulting firms or case studies, and often that's what we have to rely on. And there hasn't yet been the perfect tool for pulling this all together and triangulating. Although Jill Walter had a great meeting with her recently, and the London School is working on such a tool, so I'm looking forward to seeing that. Another barrier, of course, is that the evidence may not reach decision makers. Most of the biomedical literature is still locked away behind copyright barriers and behind subscription barriers. And that is a barrier to evidence-based global health policymaking, no question. Also, even if it does reach the policymaker, it can be presented in such a complicated and confusing way that they can't really take it on board, as John Lavis has said, professor of knowledge translation, that policymakers hear noise instead of music. So they're not really getting the evidence as such. I just wanted to give you one example of how restricted access to the literature is a live, real issue. This is not something abstract cooked up by the open access advocates like me and PLOS and so on. This is a real issue. A few years back, I was helping to run a workshop for African journal editors and journalists, and I met James Tumwene, who is a professor of pediatric infectious diseases in Uganda. And he had just been asked by the WHO to go and investigate an outbreak in southern Sudan of a disease called nodding disease. It's probably a parasitic disease, perhaps a form of neurocysticercosis. And it's called nodding disease because the child has a bite of food and then nods off, has an absent seizure. These are the states in southern Sudan where the disease is present. And of course, the first thing that James does is go online to read everything that's been written about nodding disease. But he can't. He can't because every paper is going to cost him $30, $40, and it's out of his reach. Here's a paper in The Lancet, one of my favorite journals, by the way, crucially important in global health. Many people have been citing Lancet papers in the last two days. But if you don't have a subscription, this one paper on financing of health in the poor world will cost you $31.50. Uganda's national healthcare budget, $9 per person per year, One paper, $31.50. So there's a barrier for you. A fourth barrier is that even if the evidence reaches policymakers, they may not use it. Here's Vince Cable from a tremendous presentation that he gave at ODI a few years ago on some of the reasons that policymakers might not use it. The 5 S's, Vince Cable's 5 S's. Speed, they operate quickly. They may not have time to absorb the evidence. Superficiality, they have a very wide brief. Spin, they've got to stay on message. So if the evidence doesn't fit with their message, they may not like it. Secrecy, they often make decisions in secret, and scientific ignorance. And the last barrier that I wanted to touch on that I mentioned before is this black box of implementation. And I have to say that I think one of the commonest myths in the global health community, and you hear it amongst donors all the time, is this idea that dollars can buy you health outcomes. That it's a simple equation, that if we put X million dollars into childhood vaccinations, we can save Y thousand lives. But that really doesn't take into account what happens between the money and the outcomes, this complex, poorly understood apparatus of implementation. And sometimes when you go and evaluate these programs, you find that they didn't work. And a recent example is the UNICEF Accelerated Child Survival and Development Program, ACSD, $27 million, mostly from the Canadian government, to scale up 3 packages of evidence-based child interventions. It should have worked, but an evaluation found no difference between child survival in the intervention districts compared to the control districts in Mali. And it isn't really clear what went wrong, but in a commentary in The Lancet accompanying this evaluation, Stefan Peterson said the evaluation can't really tell us what went wrong because it couldn't open up this black box. So I wanted to sort of close by looking at some of the solutions out there. This is not an exhaustive list. There are many others, and I wanted to just give you a flavor for some of the ways in which these barriers are being overcome. You'll remember that Mozambique map that comes from Cesar Victoria's paper in The Lancet on an innovative way, an innovative new design for overcoming this problem that I talked about. They are proposing that you set up a national platform of evaluation with the district as the unit of analysis, and you continually collect data before, during, and after an intervention is rolled out, using multiple methods and using multiple techniques to control for missing data and biases. There are innovations in access. The open access movement has now unlocked 10% of the world's biomedical literature. It's not 100% yet, but it was 0% just a few years ago. So extraordinary innovations in access. There are innovations in synthesis and delivery of evidence to policymakers from initiatives such as Support, from EVITNet, from my own initiative. And there are innovations in terms of doing more developing world relevant systematic reviews from, for example, the Cochrane Developing Countries field. There are innovations in policy research, a relatively new area of global health research in which people are trying to pick apart why, how, why not evidence is or isn't being used. Very nice example from the London School, Justin Parkhurst and his team. They wondered why it is that, although cotrimoxazole prophylaxis for HIV is well proven, it reduces morbidity and mortality in adults and children, very well proven. Some countries in sub-Saharan Africa have adopted it and others haven't. And they did some fascinating policy research to try and pick this apart. One of the factors, for example, that they found was that if a country had done local operational research on cotrimoxazole, they were more likely to have a policy on it. They didn't really care that much about RCTs. And there are innovations in understanding how to drive evidence into policy. John Lavis, recent systematic review, found that 3 factors predict whether policymakers will use evidence. This is the patterns that I was referring to earlier. When researchers interact with policymakers, when they understand their values, and when they time their product, a short, punchy product, to a window of opportunity. And John and his team are trying to take this even further. They are doing a randomized trial of seeing whether if you time your policy brief right, and then you get everyone in the room, researchers, evidence brokers, policymakers, get them all in the room to chat about this brief, what they call a deliberative dialogue. They're doing an RCT to see whether that will lead to decisions that are better informed by evidence. So just to close, we're trying to pull some of these lessons together in this new initiative. We're trying to be evidence-based. So, for example, we regularly meet with donors, find out what are the big strategic issues ahead for them. We're trying to grasp sort of what makes them tick. We're producing punchy briefs that we're trying to time for these windows of opportunity. And for global health, that often means board decisions where there's a big decision ahead. And we hope, and we're starting to see, some influence upon decision making. And I wanted to just conclude with a piece that I just co-authored with my boss in the August issue of Evidence-Based Medicine, where we concluded by asking, what's it going to take for policies to become more evidence-based in global health? And we said, you've got to improve the evidence flow from trial to policymaker. That's not going to be enough. You've also got to understand these social, political, and cultural influences on how policies get made. We've got to understand this complicated apparatus of implementation, and we've got to understand its impact in the real world, and we're going to need other tools other than the RCT alone. Thanks very much.
Very energetic and interesting presentation, giving us an insight into parts of the world that most people don't actually get an insight into. A couple of things I just wanted to raise with you before we move to the audience for questions. I was interested by the subscription issue there. The subscription is presumably used by policymakers. Was it in Uganda, or is it? Were you thinking perhaps internationally, WHO or something like that? I'm just trying to get in context the comparison you made.
Yeah. So in terms of journal access, journals clearly matter to ministers of health, to juniors, to staffers in the ministries, to NGOs, to say a hospital doctor. She or he may be setting policy for their country. For their local hospital in a particular country, and many of these policymakers don't have sufficient access to journals. I mean, we know that. We've heard story after story.
Okay, and how many journals actually have differential subscription rates for countries in the low to middle income countries?
So there are journals that have differential subscription rates, and there are journals that sign up to this initiative called HINARI, where if you are a very low income country, you can get access if you are non-for-profit in an institution, but that excludes a huge number of countries. Middle-income countries excludes Brazil, excludes India, and lots of people aren't at a non-profit institution, so wouldn't qualify. So it's still a huge issue.
Hi, I'm April Ballard. Thank you. That was very interesting.
Okay.
I'm just wondering, you didn't mention the WHO in any of this. Just any comments?
Yeah,
on
that's
their
a great
involvement?
No, that's a great question. For our particular group, the Evidence to Policy Initiative, the WHO isn't a target of our work. The WHO has its own processes. I mean, you heard this morning about how it sets global vaccine policy, and so on. For a variety of reasons, we have focused mostly on the donors, the financiers of global health, because we feel that that's an area where there isn't a huge amount of sort of evidence-based processes and evidence-based policy making. We have, as I said, sort of set up good relationships with them, which we think matter. And we're already, as I said, starting to see, it's very difficult to show your influence in this sort of world. But recently, for example, the Global Fund to Fight AIDS, TB and Malaria, the most important financing initiative for those three organizations, recently they've been going through this process of asking whether they should take on more maternal and child health interventions. And we prepared a policy brief where we looked at the science and the evidence of them doing so. If they were going to do so, how could they do it in a way that would make sense scientifically? What are they good at, and what is a good fit for them? And we just heard that they're going to start a pilot of adding an intervention to their financing mechanism, probably a child health intervention, and they've used our brief to help sort of think through the pilot and so on. So we see that we could have that kind of a role.
Ami Banerjee from Birmingham, and thanks very much for the talk. I wanted to ask about this comment that's often made that non-communicable diseases should learn from infectious diseases in the global health sense.
Yeah.
And I wondered how successful you think the recent efforts, particularly around the New York summit and mobilization, have been in that respect?
Yeah, that's a really great question. On the first point, I would say that I alluded earlier to the fact that I think the science of large-scale change is still quite rudimentary, and it's still quite at an early stage. But having said that, the Global Fund to Fight ATB and Gavi, the Gavi Alliance for immunisation and vaccination, they're 10 years old now. So we've got quite a lot of learning experience from these diseases. And there has been some research, some of it randomized, some of it sort of real world, step wedge and so on. And there have been evaluations of all these initiatives. And there are, I am sure, generalizable lessons from HIV, TB, malaria and so on that can be applied to non-communicable diseases. And there's a lot of talk, obviously, around the importance of community ownership, of targets that are sort of mutually agreed upon by donors and communities, of performance-based funding, results-based financing, all of these sorts of initiatives that I think the NCD community can learn from, for sure, and on the delivery side as well. I wasn't at the NCD's meeting. A lot of my colleagues were. I think the various for-profit industries influenced it not in a very positive way, and I think certainly a lot of my colleagues in the NGO world and actually in the academic world were quite disappointed by what came out.